Beyond primarily preventing HIV infection, PrEP for me is about freedom for women, about improving a woman's confidence and giving her liberty and empowering her to take ownership and responsibility of her sexual health and well being.
Okay, I'm Sophie Brady. I'm a consultant in HIV and sexual health, and I work across Bradford, Kirklees, and more recently Stockport and Tameside. And I'd like our panel to introduce themselves. We're talking about women and PrEP today. I'm going to start at the top there. Naomi.
So thank you for inviting me. I'm Dr. Naomi Sutton. I'm also a consultant in sexual health and I work in Rotherham at the moment.
Thank you. Kat.
Hi, I'm Kat. Thanks for inviting me today. I work at Basis Yorkshire in Leeds. We work with women sex workers and people who've been sexually exploited. And we've also got a young person service, and my role is around health system change.
Thank you. And Kemi.
I'm Kemi Ogunrinola. I'm community development worker, HIV prevention, social support with Yorkshire MESMAC. I'm glad to be discussing with all of you all today regarding PrEP for women.
Great. I'm glad to be here too. Thank you for inviting me. I'm forgetting to thank the organisers, MESMAC, but I think it's a really interesting topic that we've been given to discuss today. And I wanted to ask Naomi to start with, in terms of PrEP, can you explain for anybody who's new to PrEP what it actually is?
Yeah, so I'll have a go. Correct me if I'm wrong, Sophie. So PrEP is a tablet. It's an antiretroviral drug that you take once a day to reduce your risk of getting HIV. So a lot of the people that we prescribe it for at the moment are gay men, but we know that we're missing a population of women who are potentially at risk of getting HIV. And I think a lot of this discussion is going to be on how we identify those at risk, because we have to look at what the risk is from contracting HIV through vaginal sex. It's much, much lower than anal sex. It's about 1 in 1,000 from receptive vaginal sex. Whereas if you have anal sex with ejaculation, it's about 1 in 65. And then we have to look at the population that women are having sex with. What's the prevalence of HIV? And again, much, much lower. There's a higher prevalence in Black African men, but again, it's still much lower than that of the men who have sex with men population. And if we're looking at the white heterosexual male population, I think it's 0.02%. So again, we have to think very carefully. I don't want women to think everybody should be on PrEP, because it really has to be something that you consider and a risk. So we were talking earlier, weren't we? The risk to women of getting pregnant is about 85% in a year if you're not using condoms, but getting HIV will be massively lower. But again, we need to think about the risk to that individual case. And I think that's the complicated factor, isn't it?
Just to kind of go a bit back to the basics of PrEP then, Naomi, does it work if people take it?
Yes, it does. Adherence is key. So like all drugs, with antiretrovirals, you have to be taking it. And whereas men who have sex with men can take it in what we call an event-based dosing, with women, you have to take it every single day. So the studies have shown you have to have this drug on a steady state, and that's to do with the penetration of the drug into vaginal tissues, really. So yes, incredibly effective if taken correctly and taken every single day.
And is that the same for cis women and trans women?
So trans women, if they're trans women, if they're having anal sex, obviously they can take it as per men who have sex with men, because they'll be having anal sex. But a trans man, if they're having frontal sex, we need to have daily PrEP. So again, it really depends on where the penis is going more than anything else. I'm trying to say this politically correctly without getting my hands tied.
So we've talked a bit about you've talked a bit about who is PrEP for. When we're talking about more PrEP for women, or you started to talk about some of the challenges around that. And perhaps if I can bring in Kat, I don't know, Kat, have you started to have some of these conversations with women about PrEP? And can you tell us a bit about how you approach that?
Yeah, we do have these conversations, and a lot of the women that we work with are aware of PrEP and would actually qualify for it. So if they're having sex with multiple partners without condom, or potentially sharing needles, they would qualify for PrEP and might benefit from it and be at risk of contracting HIV. But it's an issue of the barriers to accessing it, and as well as adhering to the drug, because like you said, Naomi, if it's not adhered to every day, then it's not effective. And for a lot of people, it is difficult to adhere to a daily medication. So it is, both the awareness and the use of the drug effectively.
Yeah. So have you found that when you've had those conversations about PrEP, that there's been interest in the populations that you've been meeting with?
Yeah, we have some interest. I think people may be hesitant to take it because it is a bit of an unknown drug. They may be aware of side effects, things like this. Also, because of stigma, people might not be comfortable admitting that they're having condomless sex, even if they are and they would benefit from it. They might not want to say to the professional, especially someone they don't know, that they are having condomless sex, and so they won't be offered it in that case.
Yeah. And what about you, Kemi? Have you started to have some of these conversations with the women that you've met in your outreach work?
Quite, a good number of them. Even though my work is majorly, HIV prevention, during the outreaches, when we get to do testing and all of that, and that's when we have opportunity to discuss PrEP. And the truth is, the awareness is low because many of them come up, what's that? I've not heard about it. So the awareness is still low, but then we optimize all of the opportunities we have to let them know about it.
Yeah, but you raise a good point there, which is, of course, to get PrEP, you have to test for HIV, right? So it's kind of like testing women for HIV is a good opportunity to have those conversations about preventing HIV as well if they're testing negative.
For every opportunity we have to get in touch with these women or vulnerable people, we explore those opportunities to talk about how they can as well prevent themselves. So yes, we know you must test negative to be able to use PrEP. But then when we get to tell them, the next question is, how do I access PrEP? And the challenge for most of them is always that it has to be in a particular place. Can I get it here? Can I get it at MESMAC? No, you have to get to such and such points. And another question is, how about the GP? Can I get it from a GP? So one barrier for most of them is that they can't easily access it. They have to get to the sexual health clinics. And for them to know that, they also are going, for women, they don't, and especially women of color and women from marginalized societies, they usually don't want to keep going from place to place to talk about very sensitive issues they naturally will not want to talk about. So there's a kind of barrier. If few of them have actually been to sexual health clinics, and then the question is that they are asked a lot of questions to ascertain they're eligible. Yes, which I understand, because you just don't want to give PrEP to just anybody. And they also are not comfortable about the series of questions they are confronted with at the sexual health clinics.
Yeah, that's true. And Kemi, just in regards to PrEP, this is one of the reasons it's good to kind of have joint working opportunities, isn't it? Because I know I was just asking the colleagues who do outreach, or at least joint clinics with MESMAC in Bradford, about taking PrEP out to those clinics. So that there is that opportunity to deliver PrEP in alternative places. So hopefully kind of watch this space, and there will be those opportunities for those women.
Fantastic.
Yeah, and we were talking a bit about earlier, perhaps in the clinical setting, Naomi, where we've got patients who, how are we going to work out if someone coming through our doors needs PrEP? What are the kind of questions that we might need to ask to work that out?
Ethnicity is a very sensitive subject, and from our perspective in Rotherham, a third of our women are white heterosexual, and some of those were contracted HIV from white heterosexual men, but the vast majority contracted them from Black African men. But then if you're going to ask everybody the ethnicity of who they're having sex with, it sounds incredibly nosy and feels very wrong, because although it's very difficult, isn't it, assessing a risk, because you have to ask these questions in from a knowledge perspective, but without it being sensitive and insulting, because, you know, obviously not all Black African men have HIV, and white heterosexual men can have HIV. But again, I guess it's making that risk, and I don't know that that would be an acceptable question to ask anybody, unless it came.
I think it is challenging. I think it is challenging, and because I mentioned before we started recording, in terms of, you know, if you've got young Black women who are recently attending our service, having recently been infected with HIV, has there been an opportunity that we've missed to give them PrEP beforehand? And how, if that person came again, how would we do it differently? And I think that's the challenge. Without asking, you know, yes, we do say who did you have sex with, but we don't say what was their ethnicity, like you say, Naomi, and I kind of think it's understanding that. So you might say, yes, there's someone have you had sex with someone from another part of the world, but that perhaps doesn't give you the whole picture. And you do say, have you had sex with men who are having sex with other men? But as we know, sex usually is a private act, so people don't always know what somebody else is doing or has done.
Yeah.
And Kemi, I don't know if you,
you know, I don't think we'll ever know fully what everybody does in the bedroom, because, you know, nobody's ever there. And even from an individual's perspective, it may be risk-free, but actually, you know, behind it keeps us in business, doesn't it, Sophie? You know, people have sex with other people outside of relationships and marriages and things like that. So even people who may not think they're in a risky relationship could be. And again, we're never going to pick that up, are we?
Kemi, I don't know if you what are your thoughts around that conversation we've just been having? Let's say the scenario of a young Black British woman preventing her HIV. You know, what would be the way that we should approach that? Is it about information giving, which is how I've approached it? It's about actually information giving, that actually, you know, this is available. We recommend it in these situations, and perhaps you don't know someone's HIV status. That kind of thing. I don't know if you've got any tips for us, or whether.
So I think the approach is to tackle awareness creation, and first to the general population and then to the key population. But then it has to be culturally tailored too. And like you said, for you know, the Black British who, you know, has still this blood of, I mean, the Black thing in that. There's so much about culture. There's so much about, this is too sensitive. You can't ask me this. But then it probably will take a long time for us to get to that point where we can openly discuss it. But then it's a journey. So for me, it's about not being too extreme. Just try to make the person comfortable. You know, when the person understands that you don't mean harm, this is the reason I'm asking this question, I think it goes a long way. So many times there is that fear of, when I say this much, I'm going to be further discriminated against, or probably the stigma increases. You know, already I'm facing discrimination on this other end. I don't want to compound my issues. So, and that's why, you know, they kind of create a barrier. I don't want to go further than this, so I maintain my respect. But then when we make them comfortable, tell them that all information is confidential and all of that, I think we can progress. And like I said, it's not going to be fixed in one day. It's probably going to be gradual. And, you know, there's this protective factor about Black, you know, they value kinship, relationships. So, and if this person you've talked about has a good experience, she tells another person, about the good experience. Oh, and then it goes, and then one person tell another person, and gradually, it may be slowly, but gradually we get over, this barrier.
I just want to pick up, Sophie, because Kat mentioned about worry about side effects. And Sophie, you and me will have been using this drug for, a few decades with HIV patients, and I totally appreciate it's a different cohort. But yeah, I mean, obviously there are some side effects, but we know that the most common ones are that potentially can affect your kidneys, but we monitor those very, very closely every 3 months. And it can potentially affect your bone mineral density, but all the studies have shown that actually once you've stopped it, it reverses back to normal, as long as they've reached their peak bone mineral density. So we would be cautious, I suppose, in starting it in someone who's very young. Really importantly, it's safe in pregnancy, it's safe in breastfeeding. So women who are breastfeeding, the amounts in breast milk are minimal, and the plasma levels in the baby were unrecordable. So again, I think that's really comforting for women, because we worry not only about ourselves, but if we are potentially pregnant, that's a big worry. And with trans females, it also doesn't have any effect on feminizing hormones. So again, I think with regards to side effects, I think they're incredibly minimal, and I don't think they should be a barrier for anyone taking it, unless they've obviously got health problems in the background. But I think, again, it's about finding the right people.
Kat, just coming back to you, thinking about, like say, the women you work with are extremely vulnerable and have got other competing kind of demands on the times. Likewise, Kemi, but the perhaps lots of competing demands on survival, if you like. Perhaps homelessness, perhaps addiction, financial concerns. Have like you were saying, you have had the conversations, you're making women aware of it. Do you know if any of them have actually managed to get PrEP?
Yeah, we do have quite a low take up, to my knowledge, in Leeds for women of PrEP. I was going to say, I think it is really about letting people know the risks and just information giving. I think without asking all these intrusive questions, which can make the person shut down and not want to engage, just letting them know what the risks are in just sort of a rational way of different behaviors that they may be engaging in, and letting them sort of make their own informed decision based on what they know about themselves and their risks and side effects, potential health, underlying conditions, things like that. But as you're saying, I think it is definitely one of many things people will be thinking about, and it will come quite low on the list of priorities if you were insecurely housed, if you've got an addiction, and those things will come much higher on the priority list than something that is statistically quite a low chance of contracting HIV. That's going to come low on the priorities, and taking the daily medication as well is just not going to be prioritized if you're I don't like the word chaotic lifestyle, but if you're trying to survive day to day,
absolutely,
that risk that's low is not going to come very high.
So I'm thinking about now perhaps trans men and women. This webinar is about women. So in terms of trans women, Naomi, I don't know, do you think have you much experience in Rotherham in terms of trans women coming for PrEP?
No, because we don't have a big MSM population anywhere. Rotherham's it's an ex-mining village, so it's not the most diverse with regards. Obviously, we have everybody coming through, but no, we don't have. We have very minimal numbers. But compared to say Manchester or Brighton or Leeds, or the numbers will be much bigger. But definitely, again, but that's an easy discussion, isn't it? If someone trans comes in, they are high risk. We know that, so that would open up conversation. Just as if someone disclosed they were a sex worker, you could also have that open conversation, explain risk. But I think from our perspective, from a clinical perspective, I don't think we have this discussion with every woman who comes through, because one, we don't have the time. So hopefully we're targeting our conversations at the right targets. But again, as Kemi's saying, I think we probably miss the boat, I think, on a lot of women.
So if there was going to be one take-home message from this webinar today, I mean, what I'm hearing is that we've perhaps, even if the conversations are difficult to identify who's at risk, we've got to do more in terms of actually having that information out there for people to identify themselves as being at risk, if you like, and then to come to us, to access PrEP. But would there be any other kind of take-home messages that you think that anybody watching this webinar should have? Shall I start with you, Kemi? What kind of take-home message would you say from this webinar would you want people to hear from this webinar?
Other than HIV prevention, for me, PrEP is more about freedom for women. It's more about improving a woman's confidence, giving her liberty, because as opposed to the condoms, and of course we're not downplaying condoms, for the condom she has to negotiate, but then the PrEP, it's on her to do. She takes ownership of her, of her sexual health. So for me, it's freedom come to women, and I think every woman who is eligible, who is at risk, should explore it. Yeah, equity.
And actually, Kemi, although I am asking people for their kind of messages, you've reminded me actually one of the roles of us in the HIV service is to kind of, when people perhaps aren't accessing care, or perhaps they're attending infrequently, or their viral load is not suppressed, so perhaps they're taking their HIV treatment less well than we'd recommend, then to acknowledge that there are sexual partners out there who may well benefit from PrEP. And we know certainly there are some partnerships in our locality where actually there's a very open and honest conversation between partners when somebody is taking their treatment less well. So that means that is a kind of certainly a push factor to say to someone, they would benefit from PrEP. So that's kind of from the HIV, people living with HIV perspective, and thinking about their sexual partners, that they could access PrEP if they're struggling to take their HIV treatment. Naomi, I don't know if you've got any additional take-home messages.
I just say, if you are at all concerned or worried or have any questions, come and talk to us, because it's discussing those individual risks for the person sitting in front of you. And it's much, a woman might be engaging in anal sex and vaginal sex, so that puts the risk up, or, so it's all the little, it's the things that we can't discuss for every single case on a webinar. It's all about a personal approach. So if you are worried, come in and see us.
So again, you've reminded me that actually, so somebody who perhaps has a partner who's living with HIV, perhaps they've just found out that person's got HIV, PrEP wouldn't be for them, right? I don't know if you want to talk a bit about that, if someone just finds out that someone's maybe has HIV.
Well, yeah, no, definitely they should be on PrEP. So we always recommend anyone who's just started treatment. So anyone who has a partner who's just started treatment for HIV, we'd recommend that they go on PrEP to prevent them from getting HIV for at least 6 months, until the persons that they're having sex with, their viral load is undetectable. But we give like a 6-month window for that, just to make sure everybody's stable. We obviously know the U=U campaign, which is incredibly healthy and great, that people can't transmit it when on treatment. But again, there's that interim period where people are starting treatment, where we need the viral load to become undetectable before there's no risk.
Yeah, thank you. Kat, I don't know, have you got a take-home message for women and PrEP, and anybody who's watching this interested in the subject?
Yeah, I think what I'd like to see is like continued information and awareness around PrEP, so that people's knowledge grows around it and it becomes more of a common knowledge thing, rather than something that's only sort of known in specialist communities, and becomes more normalized and everyone knows about it. I'd also like to see sort of more creative approaches to accessing PrEP. So I know it's fairly new, but something like, I don't know if I'm making this up, but I think, is there a trial for like an injectable version of PrEP, like every 3 months or something like this? That would be brilliant, especially for women who struggle with daily medications, things like that, where it's not so user dependent, or something where you're able to pick it up daily in pharmacy along with your methadone, something like that, where if they're already going, and it just sort of facilitates someone accessing PrEP where it would be too great of a barrier otherwise. So yeah, I'd just like to see the conversation continuing, really.
So we're all in agreement that it's about awareness. It's about, like say, if anybody's got any concerns, to make contact with the local sexual health service to have that discussion. Mostly, as Naomi said at the start, women and HIV. Well, the chances of a woman getting HIV in the UK in most situations is lower than a gay man. Lower mostly. That's a vast oversimplification, but in most situations that is the case. But however, there are these instances where, of course, women do get HIV, and in fact, women make up a high proportion of new HIV diagnoses.
I think as well, picking up on Kat's thing about the injectable, hopefully, I'm not sure when this is going to be available for us, but if that does become available, again, it will depend on costing, because obviously we work within the NHS, but it would be an injection, I think, once every 2 months. Is that right, Sophie, of cabotegravir?
Yeah, and they've looked at implants as well, haven't they? I think studied. Yeah.
So hopefully, as things progress, we will have more options. But again, I think it is about educating everybody, and you're right, everyone making their own decision and then presenting to us. What I would say as well to Kemi and anybody who's listening is that we have heard it all, and we talk about sex all the time. And although I totally appreciate it's a really difficult subject to talk about, we're all women on here anyway, and we're all subject to the same societal cultural pressures about sex and talking about it. We're all weird about our bodies. So, anything that anybody says won't be a surprise to us. We totally appreciate how difficult it is to open up and be honest. But, hopefully anyone who does come will have a good experience if they do want to disclose anything or chat about anything. We're nice, aren't we, Sophie? That's basically what I'm saying.
I think so, yeah. we try to help, and PrEP for people who need it is one of the things we're happy to offer, and that's the challenge, I think, isn't it? Getting the people who do need it into services to have those conversations. And so hopefully together we can come up with some fantastic campaigns so that people kind of can identify that if they're at risk. Okay.
Yeah, for me, at the local level, I would say that one of the best practices has been associating with these women at risk. So it doesn't come off as being judgmental or giving an instruction, you do this. So as much as possible, I try to associate with their circumstance, and that gives them listening ear, and they feel this is someone who can relate with my situation, and that has helped a lot. But like I said, this is at the local level, at the grassroots level. I'm sure at the larger awareness creation level, we can explore as many options as are on the table, so that we can get the women on board and increase uptake.
I was just going to say again about the great thing about HIV testing. If people test negative, or if they test positive, you can access care and keep well. And if you test negative, you can access treatment to stay negative if need be. If you've got ongoing risks. So I kind of think it's a lot about the benefits of HIV testing as well.
Yeah, 100%.
All right. Thank you, Kat, Kemi, and Naomi, and lovely to meet you all in this virtual setting. I hope to see you around soon.
Thank you very much.
Great.
Thank you.
Thanks.
Bye.